Hello, everyone. How's everybody doing? Welcome to this Thursday. Plan for today is to cover psychological disorders that are most common in women. So let's go ahead and start with the mood disorders. And let's first define what is mood. I think this is going to be intuitive for most of you all, but mood, textbook definition, an enduring state of feeling that colors our psychological lives, affects our behavior and our relationships. So everybody has mood, but a mood disorder would be when there's enough disturbance in mood that is serious enough to cause suffering or impair a person's daily functioning. So they're suffering and miserable, and or just not being able to get through their day and function as normal. Okay, so let's talk about depression, because depression is considered to be the common cold of psychological disorders because it is the #1 reason why people go for help. Now, keep in mind, contextually, the anxiety disorders are truly the most common disorders, but it's depression as the common cold that creates enough suffering that women go for help. They either go to their primary care doctor, or they go see a psychiatrist, or they go see a psychotherapist to get help for their depression. So it's the most frequent complaint. And the good thing about that is it gets people in to get the help that they could use. So here's the DSM-5 definition for what is called major depressive episode. And the major depression sometimes is called clinical depression. And then lay people just call it depression. But in order to meet the diagnostic criteria, individuals have to have 5 or more of the following. This is symptoms. And these symptoms have to be present for a 2-week period. And the 2-week period is getting at the fact that this isn't just like sad for a day kind of thing. It really is persisting. And it has to represent a change from previous functioning. So one way I think about it is if you're like up here, happy and healthy and functioning fine, depression, that's really where the word comes from. Depression means there has been a dramatic decline in one's ability to function. And you have to either see, you're going to be like, well, duh, but you have to be able to see depressed mood or this thing called anhedonia. So anhedonia, anhedonia. And anhedonia is when a person loses the ability to experience pleasure or the ability to experience any reinforcement. And one way that when we ask clients about this is we will oftentimes say, are there things that you used to enjoy doing that you no longer enjoy and you no longer do? And they will oftentimes report like, oh yeah, I used to enjoy going out with my friends, or oh yeah, I used to enjoy exercising. And then they've stopped doing all that stuff. Okay, I'll walk you through this because the DSM has lots and lots of criteria associated with depression, and I'll give you my little tornado kind of theory here. So they say you've got to have 5 or more of these things: depressed mood, but we tend to see more irritability in men, and we tend to see more irritability in children and teenagers. So especially with the teenagers, they look like they've got attitude kind of thing. And it's really important, particularly for school personnel, to kind of go beyond that attitude kind of thing and ask and find out if this is really depression for kids, or for pediatricians to do the same. And then that has to be most of the day, nearly every day. The anhedonia tends to be continuous. And the most common thing that happens down here is most individuals, when they're depressed, lose their appetite and lose weight. The minority of individuals, when they are depressed, tend to have an increase in their appetite and tend to gain weight. Okay. A lot of individuals will experience insomnia, so lots of problems being able to get to sleep or stay asleep. But then some individuals, when they're depressed, get this thing called hypersomnia. And hypersomnia would be sleeping for prolonged periods of time. So like sleeping 12 hours a night kind of thing. Some individuals get this thing called psychomotor agitation, and you definitely see that when there's kind of overlapping anxiety disorder. But psychomotor agitation would be like the inability to lie down on the couch and watch TV. Like they've just got so much energy, just have to keep moving. The flip side of that, psychomotor retardation, is when all movement and everything slows. So I remember when I was doing a psychiatric rotation and I was interviewing this man who was very depressed, and I asked him a question. So let's say I just posed the question, here's the question. And he goes, yes. Like it was taking him that long to kind of process in his brain and that long to actually evidence the speech. That's the amount of retardation that we had there in that situation. Lots of people feel really, really tired when they are depressed. And this is one of the reasons why I strongly encourage, anytime I get a client referred to me, self-referred to me because of depression, if they have not had a medical checkup in a while, I usually send them back to primary care and ask them to get a checkup. Because there are other things that can cause this chronic fatigue, certain infections. It's very common in women, particularly around 30s and middle age, to get hypothyroidism as an example, and that causes terrible fatigue. So there's other reasons for this kind of thing. Some women are prone to having problems producing enough, with anemia, producing enough red blood cells for their body, particularly if they have really heavy menstrual periods. And so they bleed a lot every month, that kind of thing. So again, I send people to a physician for a variety of reasons. Feeling worthless or feeling excessive or inappropriate guilt. And we just talked about being victims of interpersonal violence yesterday. That's a common one, of feeling inappropriate guilt and blame for this horrible thing that happened to them. Because there's some sense of, I should have gotten out of that situation. I should have been able to fight him off, that kind of stuff. Down here is the problems with concentration or making decisions. And I want us to think about this anhedonia thing and this lack of reinforcement. And I think about depression. Imagine, if you will, we've kind of got this tornado or this wind tunnel. And what happens for a lot of individuals, and this is really kind of my explanation for why depression is not just lack of willpower, because a lot of people like pull yourself up by your bootstraps kind of thing. Because what happens is you will get a couple of rough events for people oftentimes, and then they start to get depressed. And then if they get anhedonia and they can't experience pleasure out of anything, then they sink further. And then they're pushing people away oftentimes with their irritability, or pushing them away because they don't have the energy to do things with other people. And then they sink a little further. Makes some sense? So it kind of spirals on itself. And one way I think about it, at one point in time, the wind tunnel and the suction's like, kind of, it's got that person down there and they're stuck. They are absolutely stuck. And they literally can't see the light at the end of the tunnel, at the top of the tunnel anymore, because they're down there in the dark and they're stuck. And so it's not a matter of willpower for people. And one way I think about clinically what we do in treatment is we can sort of see these dynamics of kind of what happened to people. And one way of getting out of the depression is not this willpower, like you're going to go all the way to the top. We help clients walk themselves out. Okay, kind of walk back segment by segment up the tunnel to get out of their depression. So that's the tornado analogy of depression. I do want to talk about something very serious here, and that would be recurrent thoughts of death. A suicidal ideation would be thinking about suicide, and suicidal planning would be actually developing a plan. And 15% of individuals with major depression eventually do engage. We don't say commit anymore, engage in suicide. And so it's a very high risk type of thing. And so there are a couple of lessons here, and then I'll talk real briefly about an intervention that we do and that many of the clinical faculty in our department have been trained in and teach and do. Any healthcare professional, I don't care if you're primary care, we may have some pre-physical therapy people in this class. If you're going into counseling, you're going into clinical psych. No healthcare provider should allow a depressed person to be in their office and leave without screening thoroughly for depression and without screening thoroughly for suicide. And then some people would add to that even screening for homicidal ideation, because sometimes there's been something going on where somebody is livid and wants to harm somebody else. Okay. So they really should be screening for that and know how to intervene. And one of the most effective interventions, there's all kinds of different ways you can kind of assess risk, but one of the most effective recent interventions is called CALM. And CALM stands for Counseling Against Lethal Means. And some of you in here may have had Dr. Jameson's suicide prevention class, and I know that's one of he does CAMs and CALMs. It is interesting that back up here in this diminished ability to think, concentrate, or make decisions, oftentimes people with major depression lose their ability to create options, lose their ability to creatively solve problems, because their creativity and their ability to think straight gets so diminished. There's an interesting phenomenon when a person who's suicidal forms a plan. So let's say it would be shoot myself, drive off the parkway, hang myself, take a bunch of antidepressants at once and poison myself, that kind of thing. Once they develop a plan, it's usually only one means. And if that means gets taken away from them, they don't go to another means. So as an example, if I've got handguns in my home and they're loaded, and that's what I say, that would be the way that I would kill myself if I decided to engage in suicide. If the physician or the psychologist works with me to secure those guns, and ideally what you do is get them out of the home. And there are ways that you can get them to police officers who will keep them safely for you. Around here, there's a lot of, when we do CALM, of having a family member outside the home keep your guns temporarily. When that happens, they don't go, okay, well, if I don't have my guns, I'll hang myself. If I don't have a way of hanging myself, I'll take a bunch of pills. When people are removed from their means, they are going to be a lot safer and a lot less likely to engage in suicide. I've got a client at this point in time, as an example, has a couple different medications that in an overdose could be lethal. And I've got her keeping them in her glove compartment, locked up in her car. So they're double locked in her car, locked in the glove compartment, car is locked up. And then what she does is dispense the amount of medication every day that she will be taking in the evening, but she has distance from that means. Does that make some sense? So at night when things get really dark, and should she get impulsive, she's not going to go in her jammies and go out into a parking lot and get into her car and get those meds. Okay. She might cry herself to sleep, but she's been distanced from the means. Questions here? I know I'm rolling fast today because as I went through what I've got in lecture today, I've got a lot of material. So tell me to stop. Just tell me to pause if you're like, whoa, you're going way too fast. I can't keep up, or you've got any questions. You just shout out and I can pause at that point in time. Just want something here. I don't want to go through all this. If they've got a bipolar diagnosis, then you don't give them a depression diagnosis. It's got to create distress or impairment, and that, I think that makes sense to you all. We need to also make sure that this isn't driven by a substance habit. So as an example, I was just counseling a client on this. A lot of people will drink alcohol when they are depressed, but alcohol, particularly in high quantities frequently, is a depressant. So we take a look at stuff like that. And then we want to make sure, this is why I refer people to get a medical checkup. We want to make sure that they don't have some underlying medical condition like Lyme disease or chronic fatigue syndrome, or the hypothyroidism, like I said, is very common in women, and it's easily solvable by taking Synthroid. And then we also want to make sure that what this person is experiencing is not simply grief and bereavement, because we actually in our culture kind of expect people to be depressed after the death of a close loved one. We expect that for a while. Okay, so we tend not to make this diagnosis right after death of a loved one, a close loved one, unless this has been going on for a long period of time. Okay, point prevalence, which would mean like right now, right now in our society, about 13% of women are depressed at right now, and almost a quarter of women will experience a major depression sometime in their lifetime. So women are definitely more vulnerable to depression than men. Men do get depressed. And there's some interesting hormonal kind of stuff we've talked a little bit about this kind of stuff when we talked about why women tend to report more stress. But in this particular study, the Women's Health Initiative study, these were the factors that they found were associated with women's vulnerability for depression. So women who were depressed had more of this kind of stuff than women who were not depressed. Less other womanly support, so less friendships or family social support. And we talked about this just in the last lecture with interpersonal violence. Some of the ways that some of the men control their female partners is by preventing them from being around family or being around friends. And that's a tremendous loss for women, because women get most of their emotional support. They can get it from men, brothers or dads or partners. But many women get their emotional support from other women, their friends and their family. They found that women who were obese and had a poor diet were at higher risk for depression. And one way I kind of think about that, we're going to talk about issues associated with obesity next class. And there's a lot of stigma attached to obesity that tends to drive psychological distress. But another way of kind of thinking about this is we are what we eat. And if we eat really healthy foods, then our body's going to maximize its health. As well as, you all need to know that the neurotransmitter substances in our brain, they're made from our food. They got to come from somewhere. They're made from our food in our gut, in our gastrointestinal tract. Okay? So if you've ever wondered where dopamine and serotonin and all that stuff comes from, so eating healthy food and then having a really healthy biome, having the healthy bacteria and the probiotics in the body, because we're seeing some individuals, you tend to see a lot of GI stuff associated with mental illness. And it's no wonder when you start thinking about these mind-body connections and what's going on in the gut that feeds neurotransmitter substances to our brain. Lack of exercise is a risk factor I, on a regular basis, recommend to my clients, particularly for anxiety disorders and for depression, that if they're healthy enough to exercise, I really encourage them to do so. If they're not healthy enough to exercise, I send them back to their physician to do a screening and see if we can get them healthy, and if they're healthy enough by their physician to exercise. If they're really in serious illness, so let's say they've had a heart attack and they're depressed, then I send people to a cardiac rehab program where they're getting medically supervised exercise in a comprehensive program where they're focusing on nutrition, stress, exercise, all that stuff. Poor sleep quality. One of the first lines of defense when we're working with clients with depression, if they're having sleep issues, there are all kinds of wonderful cognitive behavioral therapy things that we can do to help them learn how to get better quality sleep. And better quality sleep for a lot of people does a lot to lift them out of that tunnel. You know, if you all know this, you know, you can have a couple of nights of bad sleep and you just start deteriorating emotionally and physically. Actually, people get fibromyalgia, kind of achy pain in their bodies when they have extreme sleep deprivation. They found that the women that were more likely to be depressed were watching a lot of TV. I regularly counsel my clients on the behavioral activation stuff would be exercise, getting out there, being social, doing the things you used to enjoy doing. But also I will regularly counsel people on restricting their news consumption or restricting other social media consumption, because for a lot of individuals, the news and certain types of social media really make them feel bad. It's easy to watch the news and feel bad about what's going on in the world. It's rare that there are uplifting stories that they're feeding you. They're feeding you stuff that is all the bad that's going on, and they want to keep you on their network. Endocrine imbalances, there's a really interesting thing with the hormones in women. And obviously we've got fluctuating hormones for our monthly menstrual cycle, start of menstruation in the teen years for many women, young girls and young women, is a risk factor for developing depression, anxiety disorders, and eating disorders. And then we get these shifts in hormones during pregnancy, and then we get these shifts in hormones at menopause, like around age 51-ish for most women in the US. So the interesting thing though, is that when you measure hormone levels in women who are depressed versus women who are not depressed, you don't tend to see a difference in levels of estrogen, testosterone, progesterone, that kind of stuff. But we do know some women are more sensitive to the fluctuations. Some women have the fluctuations and it's like no big deal. And other women have very dramatic emotional and behavioral sensitivity to the fluctuations. And so just as an example, women who have depression surrounding their menstrual cycle are more likely to have depression during pregnancy, postpartum, after pregnancy, more likely to experience depression during menopause. They also found that women had more chronic pain, like fibromyalgia, and then women had more autoimmune disease relative to men. And I've got some friends that have some autoimmune diseases, and it fluctuates, but it can be quite gnarly for them. I really feel for them when they have those flare-ups. The brain chemistry part we've talked a little bit about. They found that women who had more of a pessimistic outlook on their lives and the world and their future versus women who were more optimistic were more vulnerable to depression. And that's something that cognitively we get in there and we really try to help people deal with when we're doing psychotherapy. And then they also found that religious service attendance was beneficial in predicting happiness and health for women. And those who did not attend religious service were more vulnerable to depression. And I've touched upon that a little bit. There's the whole social atmosphere that is going on there. There is the whole social support that is going on there. Many churches and synagogues do a lot of social work, a lot of wonderful social work for their congregation, their members. That we talked about that idea of like being able to pray and release one's woes and concerns and the goal setting that happens during prayer. And then, I feel like I've got one more thing. That sense of connection. And there's one more thing I'm trying to remember here. A sense of meaning. And for many individuals, belief in heaven, the idea that beyond life, there's still something wonderful waiting for me, can be quite beneficial. And I feel like I'm missing one more thing on the religious service attendance. The social support, the prayer. The idea that other people could be praying for you when you're ill or when you're, injured, that type of thing. So lots and lots of psychological things are going on there. So if we're working with a client who's depressed and they've stopped attending, in the behavioral activation, we encourage them to get back into that. If they are not a religious person, we oftentimes will do some values work, not trying to get them a part of a religion, but some values work to try to help them understand where are they getting their meaning in their lives and what's important for them. And that's something that we do a lot when we're doing acceptance and commitment therapy. So any questions or comments?
So looking at it from a COVID perspective in a sense.
Yep.
Because obviously a lot of these factors just come from the fact that we're in a pandemic. From a psychologist perspective, I guess, how are you, or what are you doing with patients who are coming in, with depression, who can't really change a lot of this, I guess?
That's happening. Well, we think there's a lot more depression. We think there's a lot more suicide likely going on during this pandemic for a variety of reasons. That's a really good question, Kiara. Some churches, synagogues are meeting in person. I know when I bike around on nice days, when I bike around on a Sunday and I see that happening, I cringe because I'm like, that's going to be a super spreader. But then the flip side of that is there are a lot of people that are feeling isolated. They're not shaking hands and hugging people and seeing people in these religious services, or they're doing what my church is doing. They're Zooming. And I struggle with that. It's just like, it's not for me. It's not at all the same. So yeah, a lot of people are being hit hard on a lot of this stuff because of the pandemic. So yeah, good question. Okay, let's talk about seasonal affective disorder, or SAD. We see a good bit of this here in Boone. Whenever I'm working with my clients who have a history of depression, and particularly in the fall and early winter, they start describing to me that they're feeling worse. They oftentimes haven't put their finger on the fact that it's winter, and there are some factors that are occurring during winter. And I have prescribed on a regular basis full spectrum light for my clients. So this tends to be the atypical symptoms in major depression. You tend to see more increase in appetite and weight gain. And you get a lot of people reporting that they want carbs and they want fat and they want salty, crunchy. It's kind of interesting how, the cravings even fit certain patterns with that. And weight gain. You tend to see more hypersomnia and SAD, sleeping longer periods of time, which in terms of evolution actually makes a little bit of a sense. Why not sleep more when it's dark longer? Yeah. What are you going to do all night long when it's dark, kind of thing? A sense of lethargy and fatigue and heaviness in movement, kind of that psychomotor retardation that we talked about, and social withdrawal. What does this look like in the mammal kingdom? What's happening to some of our human being friends? Based on
hibernate.
Yeah, it starts to look like hibernation. And we've got this really interesting kind of phenomenon happening. And certainly it makes sense that we see more SAD during winter, whenever winter is for people in the world. And some of it has to do with like cabin fever, and you're getting on each other's nerves at home, that kind of stuff. And you can't get out and do all the stuff you wanted to do. But a lot of it has to do with less full spectrum light absorption. And isn't it fascinating that when we look at how the color of people's skin across the globe and how we have evolved over time, white people tend to absorb more full spectrum light. Dark colored skin people tend to absorb less full spectrum light. On the globe, where are the white people in terms of evolution and history? Right? Where are the dark people in evolution and human ancestry? Surrounding the equator. Okay. So doesn't it make some sense that developing lighter colored skin would be adaptive if you're in those places that have a lot less light at particular times of the year? So again, full spectrum light, you can buy it nowadays on Amazon. Used to be kind of hard to find those lights, but now they're easily available. When I prescribe that for people with seasonal affective disorder, I encourage them to do the full spectrum light in the morning. You do not want to do it in the evening. You will have yourself a little mania and difficulty sleeping, but using it in the morning, kind of like artificial sunrise type thing. It can work very quickly for people too, in helping them lift their depression. So nice little intervention. I much prefer that over antidepressant use. We'll talk a little bit at the end of the lecture today on antidepressants, but sometimes the antidepressants can be helpful for these individuals also. Okay. Some stats. Once a person has a depressive episode, they are going to be more vulnerable to a relapse and developing another episode at another time. So 55% who've had one are likely going to have another. And in women, like I talked about, that oftentimes it can fall into certainly life circumstances, but a lot of times it's going to fall into one of those hormonal fluctuations at some point in life also. A word on antidepressants right now, though, and psychotherapy. People, and we've seen this in longitudinal research, I'm not making this up. Individuals who have attended psychotherapy for major depression are less likely to have relapse in the future. And a lot of that is because they have gained a bunch of coping skills. And I like to even think about a toolbox of coping skills, like we talked about in the stress lecture. The research on individuals who have taken antidepressants for their depression, though, the taking of the antidepressants actually increases their risk of relapse in the future. And some of that thought is the idea that replacing that artificially, those substances in the brain, then the body and the brain becomes less apt at doing that for yourself. Okay. Okay, we see a lot of overlap between depression and some of these other things. A lot of overlap between panic disorder, which we're going to talk about today. And panic and major depression is a gnarly combination because you've got this pessimism and this down and this lack of problem solving. And then you've got these bursts of anxiety and panic attacks that make people absolutely miserable. So it's a bad combo. Substance abuse, you see a lot of individuals attempting to self-medicate. There's some really interesting longitudinal data on cigarette smoking in women that they overlap. And so there's a lot of thought that women start smoking to self-medicate depression. But actually what the literature suggests is that cigarette smoking makes them more vulnerable for depression in the future. So there's some bidirectional influence going on there, but it's more the smoking predicts the depression later on. Overlap between personality disorders, we're going to talk about these today, and a lot of overlap between depression and eating disorders in women. Okay, I'm not going to spend a whole lot of time on some of the theories of causing depression, but I will talk just quickly about these. So the Freudian psychodynamic theory is the idea where there is oftentimes loss, okay, some loss in life. So it could be a love loss, it could be loss of a loved one, it could be loss of a career, getting fired from a job or being laid off from a job. And Freud spent a lot of time talking about taking, this is sort of that women's internalizing stuff, taking the yuck and eating it and internalizing it, and sort of like, it's almost like the self-blame piece to it. Well, I got laid off because I suck, or I got victimized because I didn't fight back, that kind of stuff. And I'm not going to spend a whole lot of time here on the psychodynamic, but I just wanted to get a little feel for it. The humanistic folks, they talk a lot about loss of meaning. So you're seeing some themes of loss. And again, when I go back to that wind tunnel kind of thing, there's usually some events that create loss that get that started. So loss of purpose or meaning. So this could be, as an example, a woman who feels empty nest when her kids leave the home. I had so many people when my sons left home to go to college, they were like, are you sad? Do you miss them? And I remember like saying to people, it's like, well, yeah, I miss them. And yeah, when I see them, it's even a more special event. We have more fun together when I see them, occasionally. But am I sad? No, I'm clapping. It's like, be free, fly. I've spent, over 18 years teaching you how to live a life kind of thing. It was definitely not the loss, that sadness kind of thing. Some other women, as an example, feel great loss when they retire, as an example, or when they have a demise in a close relationship. So it could be a close friendship, it could be a romantic partnership. It makes a lot of sense that would be a kindling for depression for a lot of women. The learning perspective, and we've got two kind of different theorist here. Lewinson says we get depressed when we lose reinforcement in our lives. And that would fit with the loss, right? If you had this whatever that gave you lots of reinforcement, and now it's gone. But it also fits with that anhedonia, okay, in that spiraling down. Because once a person falls far enough into a depression and they get at anhedonia, that inability to experience reinforcement, even though it's like right there still in front of you, but you can't enjoy it, boom, way down. Okay. And so it makes a lot of sense there. Coin adds to that piece, both the reinforcement part, that most of us get most of our reinforcement socially. We get it in our loved ones. We get it from our friends. We get it from our pets, as an example. Most of our reinforcement is coming from other beings. And a really sad thing happens for a lot of individuals when they get depressed. When they need people the most, unconsciously and behaviorally, they start pushing people away. They isolate. I've got a client right now with depression who isolates mainly because she doesn't want roommate, and she doesn't want family to know how bad stuff gets for her. And it gets bad. Okay. So she's pushed them away when she really needs that emotional support, that comfort, that companionship the most. Now, add to this, it's an interesting kind of dynamic that can happen. I'm going to go back to that interpersonal violence stuff. Oftentimes in heterosexual relationships, there's a dynamic going on in the relationship that feeds the woman's depression. And that calls for interpersonal therapy or couples therapy. But the other piece to the dynamic is that oftentimes a woman's depression, cutting man off, makes him angry, makes him hurt, but it comes out in anger directed at her. And you can see, based on Coin's theory, how we get into this really bad dynamic in a couple. Okay. So again, this is going to call, learning perspective is going to call for cognitive behavioral therapy. It might be calling for acceptance and commitment therapy, but then also interpersonal therapy. And in interpersonal therapies, you're trying to help people get back severed relationships. You're trying to help individuals forge relationships with appropriate boundaries, but still lots of intimacy and emotional support. And you're trying to help people have good bi-directional support in relationships. So particularly if they're in a role where they get called upon to take care of everybody else, but nobody helps take care of them, then that's something that we do in interpersonal therapy, is help move them towards more of a balance of that kind of stuff. Okay. Questions about these theories? More specific to cognitive therapy would be Beck's cognitive triad. And the cognitive triad, I don't have this on the slide. This is just the way I remembered it. So excuse my language. I suck all the time. Always will. I suck all the time. Always will. And I think you can intuitively see, if that's your mindset, that low self-esteem, and it's all the time, and it's going to be in the future with the pessimism, that's a formula for being depressed. Okay. Alloy and Abramson, they take it a step further. So Beck would say you got this negative way of thinking. Alloy and Abramson would say that some people who are depressed actually see themselves and see their lives happier and healthier and better. Oh, no, I'm sorry. That depressed people actually see their lives more realistically. Happy people see their lives through rose-colored glasses. Back when I was in a classroom, I would illustrate this and say, raise your hand if you think you're better than the average driver on the road. And just about everybody in the classroom raises their hand. Well, that can't be, you. 100% of the class can't be better than 50%, right? So it's that kind of like, well, but I'm a great driver. You know, those idiots out there, they're the ones that are terrible drivers, especially with the Florida plates, right? That's what we do in Boone. That's how we think. Okay. Another, to kind of fit in with this, Langer, in this illusion of control, she did some really cool lottery study stuff. This is Ellen Langer. And what she found is that people who were depressed would not gamble in a lottery quite like people who were happy and healthy, because the people who were happy and healthy were like, I'm good luck. And I'm much more likely to win this lottery than other people. So they were more likely to gamble as opposed to be realistic. Okay. So it's not just negativity that drives depression. It's actually some of these illusions and these self-serving biases that some of us have that keeps us happy and healthy, which creates a really interesting intervention and an ethical kind of dilemma when we're in therapy, because we're trying to deliver some disreality to people at times. We're trying to give them some of those biases to help lift them out of that depression. Okay. And one way that we do that is we point them to the really good stuff in their lives, or we point them to their strengths on a regular basis and downplay. We definitely don't point them to their weaknesses or point them to the bad stuff, as an example. Seligman's learned helplessness. This is really interesting. I know somebody who studied under Seligman. He's got a really interesting story too that he talked about. A lot of the theoretical work that he did was after his daughter, one day they were out gardening together, and his little girl daughter said something like, "Daddy, why are you always so grumpy?" And he was like, "I didn't realize I was so grumpy, but apparently I'm grumpy." And then I know somebody who studied with him who has said, "Oh yes, Seligman is a-hole." I was like, okay, interesting that you've got this guy with this kind of personality who has developed these theories of depression. But his work with dogs, he's done some really horrible stuff in the lab to show this learned helplessness. So you've got this dog in a cage, and there's two pads, and there's a barrier where the dog can jump over the barrier. And then the researcher alternates the shock pad. So little doggy's on one side of the pad, and they turns on, it's like, and he jumps over to the other side. And then they turn on the shock pad, and the other side, doggy jumps back over. And after a couple of tries of this, the doggy develops learned helplessness, curls up in doggy depression, and just takes the shocks, just takes them. But then the researcher turns off the shock pad permanently on the other side, but the doggy doesn't jump anymore because it's learned it's not worth it. It's not going to make things better. Even though if they would just jump one more time, they'd be free of shock. Okay. And many of you, I think, can relate to human experiences. If you are out there getting punished and getting punished, getting punished, getting punished, it's no wonder people just sort of curl up and isolate and like, I'm not going to be a part of any of that because it's punishing and it's not reinforcing. Okay. Questions on the theories of what causes? All right, I'm going to keep moving forward. We've talked about cognitive behavioral therapy is good stuff, interpersonal therapy is good stuff, couples therapy in the situation where there's that partnership dynamic going on. The medications that are used, I'm not going to spend a whole lot of time on this stuff. There's the old-timey meds, and then there's the new-timey meds. The contemporary stuff are the select serotonin reuptake inhibitors. And we'll talk a little bit more at the end of this lecture on antidepressants. But I just want you to know this is the stuff that we know from science to be effective in helping women. And now I'm going to shift over to the personality disorders that are common in women. So all of us have personality, okay? Not all of us have personality disorders. I don't think I have a personality disorder. But these are when individuals have very rigid patterns of behavior and ways of relating to others. So they do the same thing in the way they operate their lives. They do the same thing in how they operate in relationships, and they're not very flexible. And because they're not very flexible, they're not able to adjust to different environmental demands. So as an example, I don't know the data on this, but my hypothesis would be quarantine has been harder for personality disordered individuals than non-personality disordered individuals, as an example. Personality disorders are very resistant to change. There are even some mental health professionals who write these individuals off and say, there's nothing I can do to help you. There are some mental health professionals that take the idea, and I love this part, helping these individuals find environments where they thrive or find careers where they thrive. And then there's some mental health professionals, Marsha Linehan as an example, as somebody who has her own very public history of borderline personality disorder, has done wonders in the mental health field in developing dialectical behavioral therapy to treat individuals with borderline personality. So there's other mental health professionals who believe that there's a lot that can be done to help these individuals. It's just long-term therapy. It's not going to be one of those brief things that help some folks. Personality disorders are ego-syntonic, and let me define this kind of thing. Let me first do ego-dystonic. Ego-dystonic would be having symptoms and suffering that feels like it's not who you are. That's why the depressed people go get help. It's ego dystonic to them. They're like, and they come in and they're like, oh, I'm miserable. This is not who I used to be. I am miserable. I need help. Can you help me? The flip side of that, ego-syntonic, would be, and I'll give you an example where I did an intake. This was a young man. It wasn't a woman, but it was a young man. And I was doing some postdoc hours over at the counseling center. And I invite him to tell me why he's there that day. And he launches into story after story after story after story of all the people who have screwed him over. Girlfriend left him for best friend. They both screwed me over. My parents screwed me over. I lived with my grandma. She screwed me. And grandmas don't screw people over. But anyways, it was just like boom, 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 boom. And I remember kind of sitting there and feeling it going, either you have the worst luck in the world or you've got relationship problems. And I wonder if they're coming from you. But that's not how he came and presented. He didn't come and go, I need some help becoming a better person so I can have better relationships. It was screwed over, screwed over, screwed over, that kind of thing. You get it? Get the ego-syntonic piece to it? One way of thinking, we haven't talked about the DSM axes. I won't go into this, but I will tell you this one story about one of my colleagues when I was supervising him in his postdoc hours. He had this woman, this client in front of him, and she was going, like, it was the first session, and she was just like exploding and going on and on about her life. And he said his first thought, and I've had this experience at times before, he said his first thought was like, oh my gosh, this woman needs professional help. And then the second thought was, oh my gosh, that's me. And that's what that experience can feel like at times on the other side of this. Okay, so let's talk about borderline personality disorder. And I want to put this into context because there are a lot of mental health providers who have a very negative label and thoughts about people with BPD. And I can tell you that in doing therapy with people with BPD, it can be very challenging as a mental health professional. But I feel like I have an understanding of where this comes from. And that bridges and gives me a lot of empathy for these individuals. Okay. As one example, we just covered the lecture on this. A lot of these individuals have experienced trauma. They've experienced verbal abuse, physical abuse, sexual assaults. And again, I have a lot of empathy for that. And then the second thing I'll tell you a little bit about here in a bit, but let's just kind of go through. This is when there's an instability in self-image, relationships, affect, roller coaster emotions, not feeling like they're a whole complete person. A lot of times reporting like they feel empty. They feel empty, so they need other people in the world to fill them up. There tend to be these really frantic efforts to avoid real or imagined abandonment. These are people in friendships and relationships where the relationships tend to build very quickly. What feels like chemistry, romance, soulmate stuff, okay? But then there becomes this very clingy dependency and this absolute need to keep this person in their lives to keep them feeling like they're psychologically stable. And boy, does that create for intense and roller coaster-like relationships. So patterns of those relationships alternating where they will idealize somebody too much, put them way up on a pedestal that they usually don't deserve, and then devaluing them as soon as the BPD person feels bad. It's like, you've made me feel bad. How dare you hurt me like that? Kind of thing. So very dramatic in the relationships. We'll talk about these behaviors and these emotions first, and then we'll talk about where this comes from. Lots of self-harm and lots of self-mutilation. Now, keep in mind that there are people, and it even seems to be a little bit more trendy nowadays in younger people than it was, say, in my generation or generations in between, where there are a lot of individuals who engage in self-harm that do not meet criteria for borderline personality disorder, okay? But people with BPD do tend to be frequent self-harmers, and they're usually engaging in self-harm when they are under great distress, okay? Sometimes the self-harm, we have to get in there and assess for this. Sometimes the self-harm is merely a coping mechanism, and sometimes the self-harm is practicing for suicide attempts. And some individuals self-harm and it never escalates, and some individuals self-harm and it does escalate and can result in suicide. So again, we got to get in there and assess that stuff real clearly. Lots of suicidal ideation. Marsha Linehan, like I've talked about, she is really good at training individuals in how to intervene for these BPDs with history of suicide attempts or frequent suicidal ideation and planning. And the term comes from, this is a psychodynamic term, but just so you know, like, what's the borderline deal here? These are individuals who are extremely neurotic, okay? Lots and lots of suffering, lots and lots of impairment, problems in relationships, lots and lots of neuroses. But during times of intense stress, these individuals will jump over into either a dissociative episode and disappear, or a psychotic episode where they're out of touch with reality, or a manic episode where they're out of touch with reality with a lot of energy. And so that's where the borderline term comes. They're in a precarious place where they're oftentimes feeling horrible, but it can get really intense and they can rotate over here. And it's the rotate over there that usually gets people hospitalized. Okay. And so these individuals, just they're frequent flyers in mental health. About 20% of individuals who are in outpatient treatment for mental health are borderline, but they make up 10% of inpatients in an inpatient psychiatric hospital. So frequent flyers in mental health and more commonly represented in psych hospitals. Then there tends to be a good bit of impulsivity, and the impulsivity is usually desperate attempts to feel better and get some reinforcement for a little while. So these might be individuals who go and max out their credit card, go and have casual sex with others and put themselves maybe in precarious conditions, a lot of substance abuse, a lot of binge eating, just lack of balance in their lives, a lot of impulsivity that ends up having short-term reinforcement, long-term consequences. Now, I do want to talk developmentally about this briefly. And this is a part that gives me empathy for these individuals when they can be very challenging in therapy. These are usually individuals that are very, very sensitive. They're born as sweet, sensitive souls. And you drop a person with a sweet, sensitive soul who is not tough on the outside into a chaotic environment. Okay. And one way of thinking about it is, you know, how our skin protects us. I think about people with borderline, like not having skin, like, so everything hurts and temperature changes or feel so dramatic. Whereas other people just have like normal skin and it protects you from injury and it protects you from dramatic temperature changes. So you drop a sensitive soul into a chaotic environment where they have to tiptoe around, where they have to deny their own emotional experience because nobody is validating their emotional experience. And nobody is not only not validating what they're feeling, they're not helping them soothe and calm down. And so I think about a little kid that, like, falls over and starts crying in a family where there's abuse going on and there's alcoholing and drugging. And instead of the kid getting comforted, the kid gets yelled at, or the kid gets beaten for crying. That is very different from a kid that falls down and starts crying in a really healthy environment where you go scoop them up and you're like, ooh, you've got a knot on your head. You must have hit hard. That must really hurt. Does it hurt? Let's get the ouch mouse. Let mama kiss your boo-boos. Soothe, 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 soothe. Their feelings have been validated. Their pain has eased because you've helped them cope with their pain. There's love, toleration of emotion. There's a lot that's going on there that's not going on for these people. So it's no wonder that a lot of these individuals have this interpersonal violence background. Questions here before I move on? Another one that we tend to see a little more in women is histrionic personality disorder. And I hate the feminist part of me hates the idea that a lot of people stereotype women can't control their emotions. When Hillary Clinton ran for president, that was a big to-do. Like, what's she going to do on her menstrual cycle? Although I'm sure Hillary was past menopause. Is she going to be emotional? Is she going to be able to regulate her emotions in the office, that kind of stuff? And so I hate when that happens. But having seen this in therapy, these individuals are over the top. Okay, kind of over the top. This used to be called hysteria by Freud. Now we call it histrionic personality. Lots of roller coaster emotions, lots of drama, lots of craving attention, craving glamour, craving novelty. These individuals tend to be very provocative and almost like flirty with everyone. So not just, flirty with somebody they're romantically attracted to, but kind of just provocative with lots of people. And it's no wonder that they have strained and superficial relationships, because they can be very appealing initially. Like, really, this is a cool person. They're very expressive and they're cool and they've done some really cool stuff in their lives, until you realize they're all about sucking your energy and they're not giving anything back. Okay. And we think everybody with these personality disorders has deep wounds. It's no wonder that the psychodynamic and the Freudian people have really done some marvelous work in helping us understand personality disorders. Like I said, Marsha Linehan's stuff, the dialectical behavioral therapy, that's more cognitive behavioral and it's more acty. It's not psychodynamic, but very effective in treating these disorders. A lot of these people have wounds. And in this situation, it's usually somebody who feels like they're crap with terrible self-esteem. And so they're trying to get it artificially. And a lot of these individuals do well in career matches, like I talked about. That's one of the things that we try to do. They do well as like actors, or going into modeling, or musicians, where, they're rock stars up there with the audience cheering for them. They're getting what they need a lot of times out of those careers. Right? I'm not going to talk about the weight management woman. Try to limit the story so we can keep plugging away here. Anxious or fearful. This would be individuals who are so avoidant that it's creating all kinds of problems in their lives. These are individuals who are terrified of getting criticized or rejected. They oftentimes won't enter relationships without guarantees. And there's no guarantee, even when people love each other and they get married and they think they're going to grow old together, sometimes that still doesn't work out. I mean, we just don't have guarantees in relationships, and lack of trust in relationships pushes people away. Lots of problems with coping skills, problem solving, feeling inadequate. I don't want to go into much detail about this. I do want to talk a little bit about dependent personality disorder. This is diagnosed more in women. And the feminist part of me says we got to be careful with that because women are socialized in our culture to be more dependent on others. And they're socialized in our culture to be givers more so than to be takers. But again, this is at the extreme. Over the top and at the extreme. So these are individuals who really have dependency needs, need to be taken care of, can't make their own decisions, can't stand being alone. They don't like responsibility. They have lots of those physical somatic complaints like we talked about. And they tend to get walked all over by other people. It's interesting how there are people out there, particularly antisocial personality disordered individuals, particularly antisocial personality disordered men, who know how to find these women. They find them, they walk all over them, they get into those abusive relationships. And because of some of these dependency aspects, that adds to all those psychological factors that we talked about as why these women don't leave. Okay. And I am not saying that every woman who's in domestic violence, and I am not saying every woman who gets abused or assaulted has dependent personality disorder by any means. I want to be clear on that. Okay. Okay, moving over into the anxiety disorders. Let me spend some time. I'm not going to do the psychodynamic view, but let me do evolutionary view, and then let me do how this blends into behavioral therapy. Evolutionarily, we are wired to condition and develop fears. That has been adaptive to Homo sapiens across all of evolution. And I want to talk about this thing called learned preparedness. Get this in your notes. It's not in the PowerPoint. And let me first give you a dog fetching example. Dogs are prepared and wired to learn how to fetch, especially certain breeds. Okay, my dog loves to fetch. And then we have this whole game called stare balls, where on a bad weather day, we do balls up and down the stairs, and he runs up and he yells and he's like, I think the neighbors think we're torturing him. He's so happy. It is very easy to teach a dog to go get the ball. The hard part is to get the dog to bring the ball back to you and drop it, right? But imagine if we were trying to train a dog. Just put yourself in the dog trainer shoes. I want you to sit. I'm going to throw the ball this way, but I want you to run that way. I want you to run opposite the ball. Would that be easy to train? Absolutely not, because it goes against a dog's learned preparedness. The learned preparedness, why does a dog chase balls? Because they're chasing prey. It's prey instinct, right? Okay, if you think about the things that human beings tend to learn fears for, it's oftentimes the most common fears that we learn are real dangers, real threats. It only becomes anxiety disorders when the learned fear to a threat becomes so extreme that it becomes debilitating, or people start developing fears to things that aren't really threatening or dangerous. Okay. Okay, so we're wired to learn anxiety and learn fears. I want you to get that. Some people, get this in your notes because it's not in here. Some people have especially anxiety sensitivity. This is Dr. Josh Broman-Folk's area on our clinical faculty. Anxiety sensitivity. And some people have less anxiety sensitivity. Like I don't have anxiety sensitivity, but I know some people who do. Anxiety sensitivity would be somebody who's on high alert for anything that could be threatening. So high alert that they misinterpret feelings, as an example. So if back in the day in Smith Wright Hall, I'm in pretty good physical shape, but every time I walked up those 3 flights of stairs, I'd be huffing and puffing at the top of the stairs, okay? But I'd be huffing and puffing and going, oh, I just walked up 3 flights of stairs. A person with anxiety sensitivity would walk up those 3 flights of stairs, get to the top and be like, holy moly, I'm going to have a panic attack. My heart is racing. I'm going to have a panic attack. Got it? See the difference? Yeah. So misattributing sensations. Behavioral theory says that we can, and here's the first part of what usually happens. We classically condition the fear. It's paired learning. So like little Albert, every time the rat came over to little Albert and they smashed the cymbals and scared the bejeebies out of little Albert, over time, he learned that when the rat came near, there was a frightening sound. So even without the cymbals, when the rat came near, he was terrified of the rat. Classical conditioning. The second part to the learning theory is once we fear something, it is our natural instinct to avoid it. And that's fine if it's something that is not debilitating in your life. I don't like spiders and I don't like snakes, but it is the rare occasion that I have to deal with a spider or I have to deal with a snake. And basically I try to put the spiders outside and let them live their lives. Snakes, I just try to avoid, just not be around. It's not debilitating. Make some sense? But when we start avoiding things that are a normal part of life, if you lived in New York City and you had a phobia for elevators and you worked on the 40th floor and you live on the 20th floor, that is debilitating for a New Yorker. Got it? Does that make some sense? So it's the combination of classical conditioning first, and then if there's avoidance and an escape mechanism after that, which we call negative reinforcement. Negative, you escape or you avoid that feared situation. The reinforcement is reinforcing more and more and more anxiety. This is why anxiety disorders, when they develop, they feed into themselves. There are natural things that feed and make it worsen. Okay? And then what we do, particularly cognitive behaviorally, is we get in there and we take all the learning mechanisms that have fueled the anxiety disorder and we nip away at them and reverse them. The cognitive theory would say, this is more that anxiety sensitivity, but if we've learned a way of thinking negatively and irrationally about threats, then cognitively we're going to have more fear and develop more of this anxiety disorder stuff. Questions here. Okay, this is some important stuff for, and I'm watching the time, I may go over today. If I go over today and you all need to jump somewhere else at 1:45, feel free. The recording will be up so you can watch the rest, but I'm going to try to plug away. We talked about, plug away and get this done. We talked about this when we talked about stress, so I'm not going to go into this again. I do want to talk about panic disorder because that's more common in women. A panic attack is when there's a short limited period of time, very intense fear. So extreme anxiety, fight or flight, freeze, intense fear develops. And there are 4 or more of these symptoms that reach a peak within 10 minutes. And it's all that sympathetic nervous system just like way kicking in. Okay, fight or flight or freeze. Some people have shortness of breath and feel like, oh, I can't catch my breath, or they feel like they're choking. Some individuals, their heart rate gets so high, the heart doesn't refill. It's pumping so fast, it doesn't refill. And if it doesn't refill, you're going to lose blood flow to the brain. And that's going to make people feel dizzy. Tachycardia is high heart rate. Many individuals will sweat. That makes some sense, fight or flight or freeze. Remember the digestive system, rest and digest is the opposite, or fight, flight, or freeze. Some individuals get nauseous and vomit. Some individuals get diarrhea during a pregnant attack, panic attack, sorry. Some individuals neurologically go numb. Again, that's lack of blood flow for a lot. Some tremble, fight or flight or freeze. Depersonalization is when you feel like you've gone outside of yourself. And that happens sometimes in panic, and it happens sometimes during a traumatic event for people. And flushing. So you get all that blood flow, that sweating, and that flushing of the skin. And it's no wonder, giving these symptoms that feel like they come out of the blue. Sometimes they come out of a traumatic event. Sometimes they come totally out of the blue. That the interpretation would be, I'm dying, I'm having a heart attack, Or here's that nervous breakdown I've been waiting for. Here we are. Okay, I'm going crazy. And keep in mind, there is no such thing as a nervous breakdown. It's just a term. But this would be one of those cases where people are like, oh, I'm going crazy, and I'm having a nervous breakdown, or I'm having a heart attack, or I'm dying. So very frightening, very, very frightening to the person who experiences this. Now, just having a panic attack does not give us panic disorder. I've had a couple panic attacks in my life, but every time I had one, I absolutely understood the circumstances. And so it wasn't like I didn't have fear about it. It was just sort of like, oh, yeah, well, that happened in the optometrist chair. And I know why, because eyes gross me out. And he was doing gross things to me with my eyes. Panic disorder gets defined as it's these recurrent, unexpected panic attacks. So they keep occurring. Or here's that negative reinforcement piece. Or they've happened once, and in that once, there's very powerful classical conditioning, followed by persistent concern of having another, worry about the implications of having another, and then a significant change in behavior, which means avoidance, which means negative reinforcement. So having at least one panic attack is the classical conditioning. These down here are the negative reinforcement that actually feeds and fuels more panic attacks. If I had a panic attack in the middle of Harris Teeter, and let's say I peed on myself, okay, that would be a bad day. That hasn't happened to me, thank goodness. But I had a panic attack and I peed on myself and people laughed at me. And then every time I would have to bolt into Harris Teeter, terrified, like I'm gonna have another panic, I'm gonna have another panic. And then I can't even go shopping. I start having groceries delivered to me. And now I can't go to Walmart. And now I can't go anywhere in public, because what if I get out there and I have a panic attack? That fear and that avoidance is actually making the fear and the panic disorder grow. Okay. And at its worst, it becomes this thing called agoraphobia, where the person's terrified to leave their home for fear of having a panic attack. Okay. I can relate to this a teeny bit. I don't have agoraphobia, but boy, the first time I actually went to the grocery store after the pandemic and the lockdown, the first time I actually took a trip to visit my parents, that was so therapeutic for me to go visit my parents, because there was this sort of like, I was like out there like, I'm out in the world and there's a pandemic. That kind of thing. It makes some sense what some of these individuals go through. This happens more to females than it happens to males, about 5.6 lifetimes prevalence. This is agoraphobia especially is very debilitating. Okay. And then oftentimes, even if we can get these folks into therapy online, oftentimes will start as online therapy and then progress to office therapy, that kind of thing. Some stats on this: 1 to 2% of adults meet criteria. This is we're back to panic disorder, not agoraphobia. But up to 50% of people have had a panic attack. So my story of like having had panic attacks but not developing panic disorder, that happens to people, okay? But again, if you understand the context, that really helps, as opposed to I just went crazy or I just lost control kind of thing, which is very different attribution. Lots of comorbidity with other anxiety disorders, and it tends to develop in people. When this develops, it tends to develop in the late teens and early adulthood. And psychologically, I think about early teens and early adulthood as oftentimes where individuals have not lost their sexual innocence, they've lost their psychological innocence. You think back, for a lot of us, we think back when we were kids and we're like, I never worried about anything as a kid. But then the teen years started and the world became real. And then there was like real stuff to worry about, as well as all the developmental stuff that teens go through, their self-consciousness, they're really wanting to fit in socially, that kind of stuff. Makes sense. Okay, last slide. This is a recent study that has taken the Center for Disease Control data that they collected between 2015 and 2018. Asking men and women about using antidepressants within the last 30 days. And there's two main effects I want to point out here. And then I want us to discuss why. SSRIs, select serotonin reuptake inhibitors. That's stuff y'all have heard of. If you haven't taken it, you've probably heard of it. Prozac was the first, which is fluoxetine, the generic. Zoloft, Celexa. If anybody's got one they want to know if it's an SSRI, shout out to me and I can let you know if I know it or if it's easily Googling kind of thing. When we looked at both sexes and then men and women separately, and then we tracked across ages here. So this is starting 18 to 39, in the 40s to the late 50s, and then 60 and over. We tend to see women are a lot more likely to be prescribed and be on antidepressants within the past 30 days, but it increases with age. So more older women are on them than, say, younger women. And then there's a gender effect there, or sex effect, I should say sex, and not gender. And then there's also a racial effect and a racial effect by age. So here in dark blue, we've got non-Hispanic white, and you see for women, white women are a lot more likely to be taking an antidepressant. You're seeing down the light green are Hispanic, so Latinx women. A lot less Black women, and Hispanic women a lot less than white women. So I'm curious your thoughts on why more women than men, why more women as women age, and why more white women on antidepressants relative to women of other races. Hypotheses. I don't have the answers here. I've got ideas. So hit me with a hypothesis. I'm going to unshare so I can see everybody, because this is the last.
For the women being more likely to be prescribed antidepressants, I'm just going back to what we were talking about maybe in like the first lecture, where women are more likely to be diagnosed with like that versus something that's actually physically happening, like a heart attack is usually like a somatic thing, if that makes sense.
Yeah. If women are emotional, they've got emotional issues. is kind of the stereotyping that can go on. Yeah. Other hypotheses.
For the age, I think older women are more likely to get diagnosed because of something that we talked about, how they're oftentimes sandwiched in between taking care of like multiple generations.
Yes, Jeremy, you're correct. There's also some other things going on there where there's an interesting generational effect of stigma. And I've even heard this in my own family. It's funny how my family will talk about another family member who's on an antidepressant and will say things like, on a really strong dose, but that same person going, well, I'm only on a mild dose. Again, there's stigma in the dose, it's that kind of thing. Older generation, a lot more stigma about owning one's mental health issues and going for psychotherapy or counseling for one's mental health issues. Your younger generation is much more likely to seek psychotherapy or seek help when you need it. Older generations, a lot more stigma there attached to that. So you got, like Jana said, the sandwiching, you've got the generational effects of the stigma piece. Some of it could be, assuming there's real need for the antidepressants, women are more likely to seek help when they are suffering, and white women tend to have more access to healthcare when they're suffering. So that could be a piece of the race effect, right? And a piece of the sex effect. But then, can somebody hypothesize another part of the race effect? I'll go then. White culture tends to be independent and less collective. Latinx and Black culture tends to be more collective, like we're oppressed, we're in this together. And you especially see in Asian culture more collectivity of like, you know, my identity is I'm one of these 15 people in my family kind of thing, and we are all in it together. Whereas white culture is sort of like, I am my own person. And if you ask me my identity, I'll tell you my education, what I do. It'll take me a while before I get to the relationship piece to it. Does that make some sense? These are just some hypotheses for that. It is my opinion that antidepressants are overprescribed, but then it is also my opinion that it really, because I've worked with people who say they have been life-changing and they have saved their lives and have really been helpful. So I both respect them, but it is my opinion that they're overprescribed. I wish that more individuals were getting referred to psychotherapy that, again, helps them build more skills, validates their emotions, prevents less relapse of psychological disorders in the future, especially depression in the future. So I'm trying not to speak out of bias. I'm trying to kind of both respect it and give you what I feel like is my professional opinion on that. Thoughts, questions? All right, wonderful women's health students. Thank you for sticking over with me because I know we ran over time, but we got the psychological disorders lecture done. Next week, we will cover obesity and nutrition, and you will have your first exam. I have a question for you on the first exam. Right now, it is scheduled on your syllabus to be taken by midnight on Thursday. If that is a hardship for any of you, because you will be attending Tuesday and Thursday lecture, or some people will be needing time to get off work and come watch the lectures. If that's a hardship for you, please contact me. Okay. And I'll work with you. All right. Y'all take care. Good to see everybody. Bye.